The broadcast is now starting. All attendees are in listen-only mode.
Good morning, everyone, and welcome to today's webinar, Supporting Patients and Families on Blenderized Tube Feeding, Beyond the Basics. Before we get started, I'd like to go over a few items so you know how to participate in today's event. We've taken a screenshot of an example of the attendee interface, and you should see something that looks like this on your own computer screen in the upper right corner. Please advance the slide. If you have joined the presentation listening to your computer speaker system by default, and you would prefer to join over the telephone, just select telephone in the audio pane and the dial-in information will be displayed. You will have the opportunity to submit text questions to today's presenter by typing your questions into the questions pane of the control panel in the right-hand side of your screen. You may submit questions at any time during the presentation. We will collect these and address as many as possible during the Q&A session at the end of today's presentation. In the handout section, the Improved Nutrition Care in Your Hospital is available for download in the handout pane of your control panel, and you may download this at any time. I would now like to introduce Cindy Steele, who will be moderating today's webinar. Cindy?
Thank you very much, Kat. It's my pleasure to welcome everyone to our Supporting Patients and Families on Blenderized Tube Feeding webinar.
Muted.
And to introduce you to today's speaker. Claire Correa is a registered dietitian and certified nutrition support clinician working since 2005 at the Vancouver General Hospital. Claire focuses on the care of tube-fed adult patients and has a special interest in the use of blended food for tube feeding, both in the acute care setting and at home. She has developed Blenderized tube feeding resources for her health authority to support patients and families. Claire recently conducted research on the perspectives and perceived expertise of dietitians on homemade Blenderized tube feeding and presented the results at the 2018 Aspen Nutrition Science and Practice Conference. And her findings were recently published in the Canadian Journal of Dietetic Practice and Research. After her research identified a lack of Blenderized tube feeding resources for patients and clinicians, Claire created naturaltubefeeding.com, a website providing Blenderized tube feeding information and developed recipes, which she has published in the Natural Tube Feeding Recipe ebook. Today, Claire is going to help us gain an understanding of the growing interest, and some might say practice change, to incorporate more food-based solutions in the nutritional management of individuals requiring tube feeding. Thank you in advance for your presentation, Claire, and the floor is now yours.
Unmuted.
Claire, I believe you have yourself muted.
Thank you so much, Cindy, for that introduction, and thank you to Nestle Health Science for sponsoring this webinar. So Blenderized tube feeding can be defined as food and fluids that have been blended as needed for consumption through a feeding tube. There are many other names for this practice, for example, blended diet, homemade formula, and real food tube feeding. But for this presentation, I'll be using the term Blenderized tube feeding, or the abbreviation BTF. The learning objectives are for you to understand the risks and benefits of Blenderized tube feeding, be able to determine when Blenderized tube feeding is appropriate, support transitions to Blenderized tube feeding, and monitor nutritional adequacy. Commercial formula has a well-established place in clinical nutrition, but blended food was used for tube feeding well before commercial products came into existence. So although Blenderized tube feeding is often seen as a new or novel practice, it's actually a throwback to an earlier era of dietetics. Thanks to decades of healthy eating campaigns, there's a perception among consumers that fresh, unprocessed foods are the basis of a healthy diet, and this is influencing the desires of tube-fed patients and their families. It's easier than ever to discover that there are alternatives to standard tube feeding formulas. If you Google tube feeding, the option of Blenderized becomes apparent within a few clicks. It's important to appreciate that some patients and caregivers have such a strong desire for a more natural tube feeding approach that they will use BTF whether or not their healthcare team supports it or even knows they're doing it. An anonymous survey conducted at the Mayo Clinic in 2015 identified that 56% of their adult home enteral nutrition clinic patients were using at least some blended food for tube feeding, despite having been prescribed commercial formula. Additionally, a survey of Ole Foundation members in 2016 found that 90% of home tube-fed children were being provided BTF for at least part of their daily intake. The same study also found that 66% of adults use Blenderized tube feeding too. These are responses from the Mayo Clinic survey of tube-fed adults who chose to use blenderized tube feeding instead of their prescribed commercial formula. The reasons included wanting a more natural choice, feeling more normal, and disliking the ingredients in formula. I think we can understand why blenderized tube feeding appeals to patients and caregivers, but as clinicians, we want to know, is it safe and what are the benefits? While the literature on this topic is limited, research has shown that there are clinical benefits to blenderized tube feeding that we should appreciate. I will be summarizing these benefits, but if you're interested in the original research, it's referenced in the handout. So, based on patient and parent surveys, as well as small studies of tube-fed children, blenderized tube feeding is reported to be better tolerated than standard commercial formula. I'd like to mention a blenderized tube feeding study conducted fairly recently in Toronto, where 20 medically complex G-tube fed children were changed from standard formula to blenderized tube feeding for a 6-month period at home. In addition to finding that the children had improved tube feed tolerance on BTF, they also found that the gut microbiome had changed for the better. Another benefit of blenderized tube feeding is that it can be significantly less expensive than commercial formula. Additionally, there's the inclusion of phytochemicals in the diet and the natural fibers found in fruits and vegetables. Also, with BTF, we have the ability to customize the diet beyond the constraints of a commercial product formulary, and it offers potential to provide nearly any combination of macronutrient breakdown. But clinical benefits are perhaps not as important to patients and their families as the emotional benefits of BTF. For parents of tube-fed children, there's a natural desire to nurture their child with homemade food. Although commercial formula provides convenience and a known nutrient content, it may not provide the same degree of satisfaction to caregivers. And when an adult loses their ability to eat by mouth, it's not just a loss of the taste of food and the satisfaction of chewing and swallowing. They've lost the experience of deciding what they want to eat, of responding to a craving, of grocery shopping, looking at recipes, and participating in family meals. The use of blenderized tube feeding may lessen this loss, as the tube-fed individual or their caregivers can continue to have choices not available to them if they exclusively use commercial formula. They can get inspired by looking at recipe books, watching cooking shows, or just wandering around the grocery store and seeing what's fresh. What we eat is part of our identity, and that doesn't have to change when a person is tube-fed. On blenderized tube feeding, an individual can have a diet that respects their personal preferences. They can be a vegan or have an organic diet, and they can select foods that reflect their culture. Blenderized tube feeding allows for more participation in special occasions and gives caregivers the opportunity to nurture their tube-fed loved one with familiar food. Meals can also be shared. An example here is of a blended butternut squash risotto recipe for tube feeding, which can double as a delicious soup to be enjoyed by mouth with family. Now, all this sounds wonderful, but blenderized tube feeding is not without risks. In terms of food safety, research has shown that blended food prepared in hospital has higher bacterial content than commercial formula. But I think it's reasonable to assume that the bacterial content of blenderized tube feeding prepared in the home would be dependent on food safety practices and comparable to foods intended for oral intake. In regards to tube occlusions, yes, this is a risk, but that risk exists for any tube-fed patient. There is really no evidence of blenderized tube feeding causing more blockages than commercial formula. And in regards to nutritional inadequacy, there is certainly a risk of significant intake variability and potential inadequacy. This should give pause to clinicians. We will not know exactly how much nutrition our patient or client is receiving if they're using homemade blended food. And that risk of the unknown or an inadequate intake should be factored into the decision making. Other risks to consider include the inconvenience of preparation. Now, this is highly individual, but some people might struggle to manage the preparation of nutritious blended meals and would benefit from commercial options instead of homemade. There's also the risk of allergic reactions, especially in children, and there's the risk of medication interactions, so education needs to be provided. Again, I don't have time to present all the literature in detail, so please look to the references if you're looking for more in-depth knowledge of the evidence. So now, having presented the benefits and the risks, the question is, when should blenderized tube feeding be considered? Well, I think it should be considered if it's what patients or their loved ones want, but they're not necessarily going to know they have the option of blenderized tube feeding unless we tell them. It comes down to one of the principles of patient-centered care, which involves informing patients or their caregivers of all their treatment options, not only the ones we're most comfortable with. For tube feeding, they have choices: standard formula, food-based commercial products, homemade blended food, or any combination of the three. For every patient, their individual situation needs to be seriously considered. What are the benefits? What are the risks? Do the benefits outweigh the risks, or can those risks be mitigated? There are many factors to consider. One of the biggest ones is medical status. Are they stable enough for blenderized tube feeding? Ideally, your patient should be well enough for intermittent tube feeding, able to be appropriately positioned for feeding, and be as responsive as possible so that you can assess their tolerance effectively. We also need to consider GI function. Do they have any contraindications to enteral nutrition? And if there's significant tolerance issues with standard commercial formula, there's not necessarily going to be success with blenderized. Comorbidities should also be considered, as this will influence what food can be safely provided. Diabetes and renal disease warrant special consideration, for example. Same for any condition that is fluid sensitive, as meeting calorie needs in a low volume can be challenging. Functional ability must also be considered. Can the patient or their caregiver manage the food shopping, preparation, and administration of blended food? If not, a commercial food-based tube feeding product may be more appropriate. But basically the question is, does the patient have enough support for blenderized tube feeding to be successful? And then there's the enteral access. Any tube can potentially be used for blenderized tube feeding, but it's important to understand what tube your patient has in place and how it may influence the safety and success of BTF. Often the tube type tells a story. If it's an NG tube, the tube feeding plan may be short-term, so you may want to question if the benefits of real food are going to be achieved. Likewise, although BTF can certainly be used in post-pyloric feeding, if a person has a J tube or a GJ tube, you'd want to know if there's a GI impairment that indicates the need for those tubes. Also, you want to consider the difficulty of replacing the patient's tube if it were to block. It's important to be familiar with the type of tube your patient has so you can determine if the risk of blockage is higher or lower. Tubes that are 14 French or greater are very unlikely to block, especially if they have straight openings at the tube tip like the tubes in the top two photos. Tubes with side exit holes should be used with extra caution, as food must make a 90-degree turn and exit by small openings. The bottom left photo is a GJ tube with this design, and the bottom right is an NG with the same potential problem. Also, please keep in mind that a GJ tube has a double lumen, so a 20 French size tube is technically more like two 10 French tubes, and therefore should be used cautiously with blended food. Although some blenderized tube feeding articles recommend a minimum of a 14 French tube size, that number is not based on actual research, and I'm aware of cases where people have successfully had blended food by tubes as small as 6 French. All of these factors need to be put into the context of the patient's individual nutrition goals. There are clinical areas where we can assume that the nutritional goal is weight maintenance, or in kids, it's more likely weight gain and growth. But there are times when the goal is something else. It's therefore imperative to understand our patient's nutrition goals, and this is usually closely tied to their health goals. If they're at a point in their disease process where symptom management is the goal, then their nutritional goal is not necessarily adequacy. So the concern of suboptimal intake may be irrelevant. If their goal is weight gain, but they require a limited fluid intake, a diet of blended food may be a more challenging way to achieve that goal. So when you're working with a patient who wishes to start a blended diet, you can sometimes have them jump right into blending, or you can start slowly. To transition slowly, you can recommend blending a small amount of an easily digested food into the established commercial formula. For example, some cooked apple and cinnamon, or a few spinach leaves, or some cooked sweet potato. In small amounts, most food have very little impact on the formula viscosity and volume, but will add color and provide some of the benefits that appeal to tube-fed patients and their loved ones. In fact, for some people, giving their usual commercial formula a boost is enough to satisfy their desire for fresh food in their diet. Now, if you're working with tube-fed children, things may be different, but that depends very much on the age of the child. blended food should only be introduced at an appropriate age. Depending on the age of the child, you could start by blending a single food with formula or breast milk. Keep in mind that foods should be introduced as per the usual progression and then slowly increase the variety of foods and amount of blended food in the diet. Now, to prepare blenderized tube feeding, you don't need much. Just a functional clean kitchen, something to strain blended food with, containers for storage, and a blender. I often hear it said that you need an expensive industrial blender for making blenderized tube feeding. This is not at all true. Nearly any blender will be fine, but weaker blenders will have difficulty blending hard foods. So some foods may have to be avoided, and the blender may need to be run for up to several minutes to achieve a smooth blend. Also, make sure to inform your patients or their caregivers that the volume after blending can be up to 50% higher than the true volume of the blend, so they'll need to allow time for air to escape from freshly blended meals. When it comes to viscosity, think about the feeding method and tube size. Thicker viscosity is fine for syringe feeding and larger bore tubes, but a thinner texture is usually necessary for gravity or pump administration, or if it's a small bore feeding tube. If the patient has a low profile tube, thinner blends are also usually necessary due to the small diameter of the extension set and the narrowing at the tube connection point. And it's not just about viscosity. It's also important to have a lump-free texture to minimize the risk of food solids causing a tube blockage. If you want to ensure a particle-free blend, you should advise patients to use foods that don't leave particles, or they can strain the blend. Now in this photo, you see a small wire mesh strainer, and strainers like this one can be found at any cook shop or even at the dollar store, which is where I bought mine. So this style of strainer works well for thin blends, but for thick blends, it's really not effective because thick blends will take hours to flow through. I found that with thick blends, you can either stir it to make it pass or use a flour sifter that has a manual stirring component. This helps thick blends pass through the mesh, leaving behind any solids. In your handout, I've put a link to the strainer I like best for this purpose. The last step in preparation of blenderized tube feeding is ensuring food safety. Of course, basic food safety guidelines should be followed at every step in preparation, but make sure to tell your patients that blended food should be max 2 hours at room temperature, max 2 days in the fridge, max 2 months in the freezer. Also, most blends will become thicker when stored and may need to be reblended with a bit of fluid to get the right consistency. When it comes to administration, for the comfort of the patient, you want to have the blend at room temperature or lukewarm. Otherwise, the administration of blended food is essentially the same as any other formula. You can feed blended food by pump, syringe, or gravity. I'm only familiar with 2 pumps for home tube feeding, the Infinity and the Joey, and both can be used for blenderized tube feeding, but I recommend the Infinity pump over the Joey, as the Joey has a hard time with thicker blends. It has a tendency to alarm unless the blend is fairly thin. With the Infinity, you'll want to advise your patient or their caregiver to remove the plastic tab from the bag to improve the flow. If you don't know what I'm talking about, make sure you follow the Natural Tube Feeding blog, as I have a detailed post coming up that explains this. A tip you can share with your patients or caregivers is that by laying the bag flat on its side instead of hanging it, as pictured here, any solids and unstrained blends will fall to the bottom of the bag and get left behind there while the fluid portion of the blend is pumped out. With this trick, food particles don't block the exit point of the bag or cause a problem in the pump set tubing or the feeding tube itself. So for blenderized tube feeding, I really like the 60 ml syringe. If bolus feeding is tolerated, then this is a great option. It even serves as a filter, so large food solids don't enter the tube. What I mean is the opening of the tip of the syringe is about 12 French and the end connector is only 9 French. So as long as the feeding tube is 12 French or larger, the risk of food particles being so large that they can exit the syringe but still block the tube is almost impossible. Also, the syringe allows for thicker blends, plus it's inexpensive, it's portable and convenient, and it creates a more personal feeding experience. For patients who wish to do gravity feeding, make sure that they have bolus gravity bags because they have wider tubing, which means that thicker blends can flow through. And if they have a low profile tube, it may be easier for them to have a straight bolus extension versus a smaller continuous extensions with a 90-degree connection. In the bottom photo, you can see the significant difference between the two styles and why blended food would have a hard time flowing through the smaller version. It may also be helpful to hang the bag higher to create a stronger gravity pull, which might improve the flow. Regardless of the feeding method, there should always be routine water flushes before and after administration of blended food. So now that I've told you how to blend and how to administer blends, I'm sure you want to know what to blend or what to advise patients and their caregivers to blend to make sure they get the nutrition that they need. So there are several strategies. A popular option is the plate method, which is where you have your patient imagine a balanced meal consisting of appropriate serving sizes, or they can actually put food servings on a plate, then blend it in the blender, adding fluid as needed until they get to the right consistency for their feeding method. With this approach, the nutrient intake isn't really certain because there's not necessarily measured serving sizes, but allows for a varied diet and a lot of flexibility. The New Canada's Food Guide can be used to help educate patients and caregivers on how to balance meals. Then there's the food group servings method, where you inform your patient or their caregiver of their goal number of servings of each food group. The number of servings needed is determined by calorie level. The USDA Choose My Plate tool is great for this because they have plans for kids and adults at many different calorie levels. The link to that website is in your handout. Like the plate method, there will be intake variability, and it's possible for a person to choose a number of higher volume, lower calorie foods, meaning they may have too few calories or very large meal volumes. But generally, overall intake is more known with this method compared to the plate method. There's also 24-hour blends, which are blends designed to provide complete daily nutrition. And this sounds like a reassuring option, but it may be the most challenging to design. And although calorie and protein needs are likely to be met, there might be more risk for a micronutrient deficiency because there's not as much variety in the diet. And when you have to blend a day's worth of food together, the blend that's produced may not be very palatable, and this could be a negative for some people. There are also what I call design blended meals, which are recipes with ingredients that have been selected to achieve a known volume and nutrient content. This approach is an evolution of the plate method. It involves some basic nutrition knowledge and a calorie counting app, but it can ensure nutritional adequacy. So you'd want to tell your patients or their caregivers to aim for a certain number of calories per milliliter in their homemade blends. This can help to track intake and make sure calorie goals are met. Regardless of the strategy you choose, there are elements of a recipe that should always be considered. So use your knowledge of commercial formulas. Don't just think about the calories, think about the calories per milliliter. A 1,000 calorie blend sounds great, but not if it's in a 2,000 milliliter volume. So ask your patients questions about the volume of their blends. Same with protein. If the protein content of the blend is low, the patient is missing an opportunity to meet their protein needs. And this is how nutritional inadequacy can happen. Also, look at where the calories are coming from and try to make sure that carbs, fat, and protein are balanced. And watch for too much added salt or lack thereof. And even for tube-fed patients, it's pretty easy to reach the RDI for sodium unless they have very few processed foods in their diet. In my experience, I found that adding table salt is usually not necessary if you take a close look at sodium intake from other sources. Of course, that would be important to assess on an individual basis. So to get you thinking about calorie density, here are the calories per milliliter of some common fluids. You can see how using a cup of broth instead of a cup of whole milk could reduce the calorie concentration of a blend. So it's important to explain this to your patients or their caregivers. The liquid they choose to add to a blend has a significant impact. So using water or broth could be a missed opportunity for calories or protein. Now, all produce is nutritious, but I look for foods that provide significant calories and/or protein in an equivalent serving as other foods. So for example, if your patient uses 1 cup of zucchini in a recipe, they'll get about 30 calories. But if they use a half cup of peas and a half cup of avocado, the veggies in their blend will contribute about 175 calories plus 4 grams of protein, while having really a comparable impact on the viscosity of the blend. And it's just as important to recognize there are some vegetables that are low calorie but have a negligible impact on viscosity and volume when blended. Those would be leafy greens. So basically, they add negligible calories, but they benefit the nutrient profile while having hardly any impact on viscosity or volume. You want to keep the serving sizes of about half a cup of fresh greens, and always review the patient's medications to identify vitamin K sensitive blood thinners before recommending this. So for protein, where possible, you want to have foods that contain a lot of protein in a relatively small volume and are easy to blend. All the foods I've listed here, I've tested myself and find them to be very well suited to blending. The key with carbohydrates is to select foods that won't suck up all the liquid in a blend, leaving it too thick and requiring dilution with fluid. Overcooking grains can reduce this effect. Same with consuming a blend right away after it settles, rather than letting it sit for long periods, allowing it to get thicker over time. I've had some trouble with short grain rice not breaking down completely when blended, but for me, long grain rice blends easily. Dry foods like toasted bread, cereal, and crackers will disappear into nothing in a blend and are a really easy way to add carbs. Also, quinoa is great for blending. It doesn't absorb much liquid and provides a lot of protein. So there are ways to boost the calorie provision of a blend without greatly increasing the volume. For example, a tablespoon of olive oil will boost the calorie content of a blend by 120 calories with hardly any increase to the volume of the blend. Nut butters and honey also boost calories in a very low volume. And this is a photo of my blended French toast recipe where I used a tablespoon of maple syrup to get the nutrient density up from a 1.1 calorie per milliliter to a 1.2 calorie per milliliter blend. So what about micronutrients? I'm asked this a lot. How are dietitians able to know that their patients are getting enough if they're not using commercial formula? So we need to assess micronutrient adequacy in the same way we would assess this for our patients who eat by mouth. If a tube-fed individual has a wide variety of foods in their blended diet and is getting plenty of calories, there's low risk of inadequate vitamin and mineral intake. But you'd want to ask the usual questions. Are you using fortified grain and dairy products? Do you add salt to your food? Do you eat meat? Are you a vegan? Do you have a variety of fruits and vegetables in your diet? Depending on your assessment, you'd want to recommend supplementation no differently than for an adult or child who eats by mouth. I recommend the same approach when it comes to overall nutritional adequacy. It's the same as oral intake. Talk to your patients or their caregivers and assess how they're doing. Ask them about their weight and energy level. Ask about what they're blending and assess if their blends are calorie dense and if they're including proteins. Are their blends unnecessarily thin? Judge if their meal should be bigger or smaller. Make sure they have dietary variety and ask if they use supplements. And find out what they do if they're too tired or too busy to make blended meals. Maybe formula or a food-based tube feeding product would be a convenient alternative to homemade blends. One extra consideration when using blenderized tube feeding is that research has suggested that a person may need significantly more calories when using blended food for tube feeding versus standard commercial formula. This might be due to the gut microbiome, and I can't really explain it, but I have seen this in my practice. So you should recommend a calorie intake of at least 20% higher than the assessed needs, maybe as much as 50% higher to help ensure success. So my overall recommendations for patients and families using blenderized tube feeding are as follows. Monitor weight. If they're able to, have patients or caregivers use an app to track intake, and the free app I recommend is listed in the handout. Or you can have them count food group servings. If they're making their own recipes, have them record the volumes and aim for at least 1 calorie per milliliter. Discourage the excessive use of fruits and vegetables as they can increase the blend volume and lower the calorie concentration. You should suggest calorie and protein boosters and prescribe supplements based on individual need. But most importantly, provide support. Remember, these are people who are probably going to do blenderized tube feeding with or without your help. So even if you feel like you don't have a lot of expertise in this area, remember that you are highly knowledgeable compared to the patient or their family, and you have the skills and abilities to help them prepare a safe and nutritionally adequate blended diet. So be there for them and support them as they adjust to their feeding tube in the process of making blended meals. I promise you'll learn a lot from each other. So at the beginning of the webinar, I provided you with this definition of blenderized tube feeding. But through the eyes of our patients and their caregivers, blenderized tube feeding may have a different definition. It's love, hope, normalcy, freedom, comfort, and much more. To conclude, I'd like to share this quote from the mother of a tube-fed child. "I'm so grateful for the bridge that a real food diet creates in the normalcy of preparing and cooking and sharing. Aren't we lucky to be in a profession where we can be part of something this profound?" Thank you.
Thank you very much, Claire. I think I can speak for the audience in saying how much we appreciate you sharing your knowledge, experience, and expertise with us. We're now going to begin answering the questions submitted during today's presentation. And as a reminder, you can still submit your text questions to today's presenter by typing your questions into the questions pane of the control panel on the right side of your screen. Okay, so our first question is, Cindy, are you with us? Okay.
Can you hear me now?
Yes, indeed. Switch to computer audio and not phone call, if you could.
I did. I'm all set, I think.
Okay.
Sorry about that.
So
Okay, so we'll start with the first question. Thank you, Claire. And I just also wanted to say your slides are incredible. They're as visually appealing as the information was useful on them. So thank you for that. Let's start with the first question here. I guess I'll ask, what experience do you have, or can blended food via jejunostomy be well digested as it's bypassing the stomach? Do you have much experience using blenderized tube feeding into the jejunum?
Yes, I do have experience with it, and I found that it's been well tolerated. In fact, I've actually, in my experience, found it to be better tolerated at higher rates of infusion compared to standard commercial formula. So I know that there is some concern about the lack of the digestive process in the stomach because you are bypassing the stomach for JU tube feeding. But when we have patients who have gastrectomies, they still eat by mouth, and their food does not have a stomach to digest, and they still tolerate their food. So if you think about it, the fact that we're blending, that's already taking part of the role of the stomach to break down the food into small particle size, that stuff's already been taken care of. And we have plenty of enzymes and surface area for digestion and absorption in the jejunum and beyond.
Great, well put. We find the same thing. People tolerate our food-based formulas into the jejunum, no problem. Okay, we have one comment here that says, I suggest the basic silicone O-ring syringe. A single syringe will last for 60 days. So I'm not sure if you have, that was just a comment as opposed to a question, but I'm not sure if you use that.
I'm not sure that we have those syringes in Canada. I have not had any experience with them, but they do come up in some of the tube feeding forums I follow, and that they are, very long lasting versus the 60 ml catheter tip syringe. But I do know that the 60 ml catheter tip syringe that we have in hospital, which is what I send my patients home using if they're doing syringe feeds, those do last, at least a week, and you can even put them through the dishwasher. They will break down, but they only cost about $2.50 each. But I'm very curious about those O-ring syringes, and I would like to try them for myself and see.
Mm-hmm. I heard about them as well at the Aspen conference this year. A speaker was talking about them, so we'll have to look into those. Question, it says, thoughts on cooked versus raw foods to be blended?
Well, I guess you just always need to keep in mind, if a food would normally be cooked if you're going to eat it by mouth, it needs to be cooked. But obviously that's just basic food safety. But I think the question is probably more talking about raw vegetables and things like that. And I guess it would depend on the power of the patient or client's blender, because like raw peppers and kale with the stems on, those are harder foods to blend, but they are blendable when cooked very easily. So it might just be a matter of how strong is the person's blender. Are they able to incorporate a lot of harder raw foods into their diet? Then great. But if not, they might want to stick to the softer raw foods. Like I love spinach for blending because it just dissolves into absolutely nothing when blended. And you can use fresh, like stone fruits are great, like peaches and apricots. They blend really well from raw. So there are lots of raw foods you can include in the diet. It certainly doesn't need to only be cooked food.
Okay. Someone is asking if you can please repeat why we would need to recommend 20 to 50% higher needs with blenderized tube feeding versus commercial formula. I'm not sure.
I guess that's a hard one to follow because it doesn't seem, I'm a little bit surprised by that too, but there's been 2 studies now that have identified that you have to up the calories in order to achieve whatever the weight goal might be. But in research, it's usually been weight maintenance or weight gain. And the studies have found that they need to up the calories by 20 to 50% in order to get that goal of weight gain. So I mean, in my opinion, I assume it could be because of the microbiome metabolism, like the bacteria may be utilizing more of the food that we eat when it's less processed. And maybe the typical ingredients in a standard commercial formula being relatively simple sugars and oils and, and proteins, maybe that's just so highly available to the gut that it's absorbed 100% and utilized 100% versus food where we may be passing more of that. Mm-hmm. That's all I can come up with, and I don't really have a great understanding of it, but I just think if you have a patient who's going home on tube feeds, and if it's an adult that you've assessed their requirements to be 2,000 calories, you would be better off telling them to aim for maybe 2,500 calories. And that way, if they fall short, they're not, the falling short might be more around 2,000 calories and could still sustain them versus giving them what you've assessed their goal to be, and then if they only get in 1,500 calories, then you do have a problem.
Okay. Do you think that individuals on home blenderized tube feedings require closer follow-up rather than those on a commercial formula?
I think it would very much depend on your patient. So, with my patients that I set up for home tube feeding in acute care, there are some times that I feel like they really have a great understanding of how to prepare nutritionally balanced and appropriate calorie-dense blends, because I can spend a lot of time with them and give them a lot of information and resources. But then there's other times where patients, you get that impression like this is going to be hard for them and they may not be successful, in which case those patients I would want earlier and more thorough follow-up in the community setting. But typically, I don't really think we necessarily need to do a different follow-up plan for people who are using Blenderized. I would not think that you need to do any blood work. That question comes up sometimes just because they're on Blenderized. You would want to do what's clinically appropriate. So if there's a clinical indication for blood work monitoring or closer follow-up, then that patient should have that closer follow-up and blood work. But not necessarily. I guess it's very much individual, case by case.
Okay, makes sense for sure. Switching gears a little bit, is tube discoloration a concern over time?
It will discolor, yes, that will happen, and that's something that, with the recipes I've designed, I've stayed away from foods like beets. I've stayed away from turmeric because I don't really want someone to try one of my recipes and then have their tube be, bright pink or bright orange after. So some foods are staining than others, first of all. And there's some people that do not care that their tube has changed color. And again, if you're working with a patient who has a low profile feeding tube, those extension sets, I find that they're even more porous than a regular feeding tube. So those extension sets, they just color very quickly and quite dramatically, but they're disposable. So it doesn't matter because you can just use a new extension set if you get to a point where you're finding your extension set is just far too discolored to continue using it.
Mm-hmm. Okay. Now it's asking, somebody's asking, would it be appropriate to start a new tube feed with a real food formula and gradually introduce more foods, or do you often start like somebody with a newly placed feeding tube off on commercial formulas and then gradually increase the amount of food?
So in the clinical settings that I work in, I'm in a VGH, I'm in a critical care unit and an acute care unit. And, you know, in that critical care setting, I would have my patients on a standard commercial formula. Like my goal at that period is just to meet their assessed nutritional needs, and often I have to do so in a low volume. So generally, you know, I don't know that I've had a patient start directly onto blended food, but there does come a point in their admission when it's looking like they're going to need home tube feeding, and we have discussions around insertion of enterostomies. And it's at that point where I bring up the option of Blenderized. And first of all, I see what they want. But ever since I started to ask my patients or tell them all their options, that being standard formula, the food-based commercial products, or blended food, I would say at least half of them are now opting for a food-based commercial product or homemade blended food. And usually they will have been on commercial formula up to that point. And then we do a transition. And now that on our formulary, we do have a blended food commercial product, I think I will be doing more of that, transitioning to that product, because that seems most acceptable to those patients. And then having them at home, maybe doing more of the homemade blends or finding the right balance for them. But you could start them directly on the commercial product if you wanted, and skip the standard formula step, or you could probably get them right onto blended food if that's what they really, really want, and it's safe to do so. I don't see why you couldn't.
Okay. How long do you let the formula sit to remove the air bubbles?
It seems to depend on the ingredients, but at least 5 to 10 minutes. I've learned that by, like, I would create blends that I was expecting to be a certain volume, and it would come out dramatically higher, and I would have, and then my calculations for the calorie density would be falsely low. And now I know, you know, wait 5 minutes at least, even up to 10 minutes, and you're going to see the true volume of the blend. And that by waiting that time, you're saving your patients from being fed all that air.
Okay. Okay, just looking through here. Have you had experience with a client using Blenderized tube feeding at home and then they're admitted to the hospital? And does your hospital support that, and sort of what happens in that situation?
Yeah, I think we're going to see that more and more often, that patients will be doing Blenderized at home and then come into hospital settings. And I think there's a lot of inconsistency about what is accepted in hospitals depending on the hospital. I've really been advocating at VGH to support those patients. So what I have found, and this may be applicable in other hospitals, I would think, I will work with those patients to identify what do we have on our menu as far as we have a Blenderized diet intended for broken jaw patients or wired jaw patients. We also have a puree diet for dysphagia. So I look at the options on both those menus. I talk it through with the patient or their loved one, and we come up with a plan of foods that we can supply, because we do have a policy at my site, and it may be, this could be at many other hospitals, where our nursing staff won't feed a homemade blend to a patient. So the patient can have the homemade blends brought into hospital. We absolutely allow that, we encourage that, but they do need to feed it themselves or have a loved one feed it to them, unless it's a food that's prepared in hospital. So that's the way we get around that, because the loved one can't be there all the time. We have patients, you know, with neurological disorders that they can't feed themselves. So I want to make sure that a tray of food is coming to patients that is nutritionally adequate and is in texture that they can use for tube feeding. And then the staff can feed that patient if they have the time to do so, but we would always prioritize that care to make sure the patient's receiving their nutrition in the form that they want, which is blended food. Or you could use a commercial product in that situation too, and I think we'll probably see more and more of that now that we do have a good option.
Yeah, for sure. Actually, that goes well with our second last question, which is, do you find that patients or caregivers are open to using Blenderized tube feeding when it works and other options when it doesn't?
Yeah, I do. I think that whatever is going to work best to meet their goals. And there's always going to be times where making a homemade blend isn't feasible, and the person always should have a plan in place for what happens when they're not going to be able to make their own blended food. They could be traveling, they could just be too tired, they could feel unwell. There's so many possibilities, so they should have a commercial product that they could potentially use handy at all times. They should have some, you know, shelf-stable stable product, food-based, they could have that in their glove compartment in the car, that could be in their purse, that could be in an office drawer, that could be stocked at a child's school. It's so important to have that option because, yeah, I think it's important for people who want to do blenderized that they remain open to other choices, and even standard formula has a role in those situations.
That's great. Okay, I think actually I'm going to end. We have lots of questions, and we will do our best actually to address some of these. We actually have a podcast coming up that will be available this year, or in the beginning of this year. So stay tuned for that, and we'll try to answer some of these questions in that. Also, we'll have see if we can have Claire answer some of these questions and get back to the sender. But I think I'm going to end on this comment, which I think is really appropriate, and it says, "Just want to say thanks for the reminder that the patient has more options than they realize. I think this is so supportive, empowering of the patient and family." So I think I can echo that as well. It's a great comment. So with that, I'm sad to say we're out of time, and we're going to end our webinar presentation. I would really like to thank you, Claire, for sharing your experience today. And I'd like to really thank the audience as well. We've had a lot of participation. These questions are keep coming in. If you have any questions about the handouts or access to any of the other resources, please connect with your Nestle Health Science Territory Manager. And Kat, I will pass it to you for to finish us out here. Thank you again, and have a nice rest of your day.
Thank you very much. Nestle would like to thank our speaker and participants for attending today's webinar, Supporting Patients and Families on Blenderized Tube Feeding, Beyond the Basics. If you have any questions, please contact your Nestle Health representative. Once you leave today's webinar, you will receive a survey on the presentation. We would appreciate it if you'd complete that and provide your feedback. You will also receive a follow-up email within 24 to 48 hours with a link to view a recording of today's webinar. On behalf of Nestle Health Science, thank you so much for joining us today, and have a great rest of your day.